Good morning, everybody. My name is Tamsin Rose, and I have the great pleasure of being the moderator for this morning's session. And it's a session that's brought to you by the European Federation of Allergy and Airways Disease Associations. It's a patient voice for a large number of patients across Europe. This morning, we're going to ask the question, how do you care for atopic eczema? And there's a hashtag that you'll be able to see on the screen that you can use to keep the conversation going. We have a 45-minute session this morning, so it's quite tight, but you will have an opportunity to ask questions at the end. The session is being recorded and will be made available for you afterwards to watch and to share, so you don't need to take too many notes as speakers move forward. So let me now first introduce to you Ms. Carla Jones, who is on the board of EFA, and she is also the CEO of Allergy UK. Carla.
Thank you, Tamsin. My name's Carla Jones, and I'm a board member of EFA, which represents over 2 million people living with allergy and airways diseases in Europe. It's my pleasure, on behalf of EFA, to welcome you to this webinar with the question, how do you care for atopic eczema? I would like to welcome you together this morning with the incoming EADV President, Professor Alexander Stratigos. Last September was World Atopic Eczema Day, and the theme, How Do You Care? This yearly event is coordinated by EFA as the patient representative in Europe and Global Skin at the global level, with the aims to raise awareness of the atopic eczema and the impact on patients' lives. The aim is to make it at the patients at the heart of care and policy making. We bring today this theme to the European Healthcare Professionals Hub, the EADV Congress. And we wish to, as EFA, advocate for change for all of those over 200 million people about having the right for care for their atopic eczema. EFA looks at these under 3 columns: inform, prevent, and care. And caring is about having the right care for the right patient, the right treatment, the right diagnosis. But it's also about caring about people with atopic eczema and their lives, their concerns, their problems, their quality of life. Atopic eczema affects the quality of life of patients every day of their life. For the first Atopic Eczema Day in 2018, EFA published a report that looked at the quality of life in severe atopic eczema, where patients from 9 European countries reported feedback on their quality of life. 51% of those patients said they hide their eczema. 43% said their eczema makes them angry. 39% feel guilty about scratching. 39% have problems with intimacy. 34% avoid touching others, and the itching drives them crazy, 57% of those people surveyed said. And 2 out of 3 said they don't have any optimism for their life because of their atopic eczema. For us, caring is a partnership, and it's a partnership between healthcare professionals, patients, and the patient carers and the patient organisations to support them. So in this webinar, we have all of those representations in this programme in a multidiscipline way, which is what is required to really care for atopic eczema and alleviate the social burden, a heavy weight, especially for families with children with atopic eczema. On behalf of the board of EFA, I wish to welcome you. I want to thank EFA's sustainable funding partners, Sanofi Regeneron, Alliance and AbbVie for their support with this webinar. And I want to thank the speakers and Tamsin, the moderator. And I welcome you to this, what I believe and we believe is a really interesting and very vital element of atopic eczema care for patients. Thank you.
Thank you, Carla. And now, as you mentioned, this is a partnership with the EADV. And our next input is a recorded message from the President-elect of the EADV, Mr. Alexander Stratigos, who's a professor and chair of the Department of Dermatology Venereology at the Andreas Sigros University Hospital in Athens, Greece. Let's hear his message.
Dear colleagues, dear patients families, on behalf of the EADV, session, how do you care for eczema?
I apologize, we seem to be having some audio problems. Let's see if we can fix those for you.
Eczema, particularly severe eczema, affects quality of life. According to statistics, almost 10% of patients with atopic dermatitis suffer from severe forms of the disease. And many of these patients, despite care, experience severe symptoms such as dry skin, pruritus, and cracked skin that increase the burden of the disease. And these symptoms in extension cause a greater impact on relationships, on work productivity, on social and sexual life, and hobbies. As a physician, I am very pleased that our patients can now benefit by the newest treatments that promise to change the impact of the disease and the well-being of our patients. But we have to remember that atopic dermatitis is a chronic, heterogeneous disease with flares and exacerbations, and that combating the disease requires a concentrated effort by all involved with a more individual patient targeting. This is why the session today provides insight on the social burden of the disease. And as Carla already mentioned, there is a need for coordinated care that involves patients, families, and healthcare providers. It's important to remember, timely and appropriate care can lead to a better quality of life. I hope you enjoy the session. Thank you.
Thank you. And now we have two further inputs because we're now going to move to the content of our session. And we're asking the question, how do you care for atopic eczema? And the first input we're going to have is from Magali Redding, a carer and CEO of Eczema Outreach Support. And she's going to give us the reality of what it's like living with eczema, what it's like for the patient and for the family. So let's see what she has to share with us.
Hello, my name is Magali Redding. I'm the founder and chief executive officer of a UK charity for families with eczema called Eczema Outreach Support. And today I'm here to share my story of living with my daughter's eczema and dealing with it, but also some insights about how we can best help families of children with eczema. So when I got pregnant with my second daughter, I had this perfect baby image in my head, so healthy and joyful. But 2 months in Gail's life, she was diagnosed with eczema, which came as a big shock to us. I didn't have a clue about what the condition was. So, of course, it took us months to find our feet with the relentless treatments and all the creams and the garments. And you can see the bath water looking a little bit colored there with all the additives and the oats and all sorts of things we were trying to do. But it was very difficult to understand how to manage this eczema on a daily basis. And what I quickly learned is that Gail's eczema was going to have a really big impact on her daily life. Not just the treatments and the garments that you can see my little mummy there, wearing bandages 24/7, even going to birthday parties, looking lovely with her bandages and party dress on, but also the scratching and the sleepless night. We were so exhausted, and so was she, of course. And she also had food allergies and just feeling really quite sorry for herself and in pain a lot of the time, unfortunately. Eczema also had an impact on her day-to-day activities and her social life. This is a drawing that she drew when she was just a very young girl. It was Gail at the park, and everybody's enjoying themselves in the background, but she's not. She's scratching, she's hot and bothered, and her eczema is really impacting on her ability to enjoy those childhood activities, such as swimming or playing in the sun or on the grass, those field trips with the nursery, sand, messy play, cooking, and her friendships as well. School then was a big hurdle. We had to be very proactive, really, and have quite a lot of confidence in ourselves as parents to go into school and educate all the teachers. They never had to look after a child with severe eczema before. And you can see Gail here presenting her creamer award to the staff in the office who had volunteered to do her creams at lunchtime every day. And these are a few words that show the effects of eczema on learning and play at school. It really was a tough time for the whole family, and that's what people quite often misunderstand. Is this is not just about the person with eczema, it's about the siblings who don't have as much time to spend with their parents because we're so focused on looking after our daughter with eczema, and the sleep deprivation and the heartbreak to see your child in such pain, of course. So one day my daughter was 5 and she said to me with tears in her eyes, "Mommy, why am I the only scratchy girl in the world?" And that really broke my heart. But to be fair, I was also feeling like the only eczema mommy in the world, if you see what I mean. And that day we decided to set up a support group, which quickly became Eczema Outreach Support, a nationwide charity in the UK that supports over 2,000 families with eczema at the moment. And I would love to share a few insights about what we do at Eczema Outreach Support. We are there to really support and empower families, to connect them and educate others as well. So the 3 insights I want to share today specifically are that, first of all, families with eczema have different needs and the benefit, therefore, from a range of one-to-one and group services to choose from. Everybody's different. There are 2 danger transitional zones that require special attention, we've found. It's starting school, primary, secondary school. All those transitions are tricky, and adolescence, of course. And third of all, the voluntary and clinical, academic, and policy agencies must team up to improve the health outcomes of families with eczema. And in order to cater for people's different needs, we have a range of support activities that are a la carte, if you will. So personalized support to parents and carers, activities for children and teenagers specifically to build their self-management skills and confidence. And we offer a community of peers, face-to-face and online, while working with nurses and dermatologists to educate families about how to deal with eczema better. So the first danger zone, school, the main issues really are the lack of understanding about eczema and its impact on the children from the teachers and management, lack of care planning. I remember my daughter had to find somebody to apply her creams at lunchtime, and it's not a given. And so also bullying from peers. 1 in 5 with eczema is bullied at school, which is terribly sad. So the interventions we came up with are communication and care plan resources to build that skill set in families, and also face-to-face and online class workshops. Now let's talk about adolescence, such a tricky period in your life. And the main issues there is a risk of disengagement in your skincare, when really what you need to do is to take control and start self-managing. The impact on mental health and the school life difficulties. Interventions for us mean setting up the XY Club for teenagers that offers self-management resources and an app, online meetups, high school training and action planning, and also individual help and volunteering. And this is a picture of an outing to our go-karting facility in West Lothian. And all the children there have moderate to severe eczema, and they got to meet up and have a good time together. And finally, the partnership work is so important, isn't it? And it's between the voluntary sectors, the statutory and academic sectors, for instance, helping each other for research and building the patient's voice into research goals and protocols. Patient groups can deliver interesting talks at clinical network conferences. We can organize events together for families, and being part of an international group of patient charities is very valuable too. So in a nutshell, what are we aiming to do? We really are trying to improve the self-management skills and the confidence of families with eczema in the UK through the activities that offer eczema outreach support. We break isolation. We set up support and care systems in schools. We fight stigma and bullying. And we include the views of families with eczema in research and healthcare design. And here's a photo of a child taking part in our High Five Club, which is for young children with eczema, and they had to decorate their pots of cream. And he went the extra mile with decorating himself and his garments because they're part of the treatment regime. Fantastic photo. So I would like to thank you very much. And if you would like to get in touch, this is my email, and please don't hesitate to visit our website as well. Thank you.
Thank you very much, Magali. What a powerful introduction to the reality for families and patients of living with atopic eczema, and explaining what a huge impact it has on people's lives, and also the value of a patient's organisation to provide support and guidance and help so people don't feel isolated. Let's now hear from the other side of the coin, because of course a treatment pathway is a partnership between a patient and their healthcare professional who works with them and accompanies them on their journey. So now we're going to have an input from Professor Carsten Floor, who is from St. John's Institute of Dermatology, and he's going to explain from the professional side, how do you provide care for complex pediatric atopic dermatitis? Professor Floor.
Thank you very much for the kind invitation to talk about how to care treating complex pediatric atopic dermatitis. I'm Carsten Floor from St. John's Institute of Dermatology. When patients with significant atopic eczema come through the door, that is for some a heart sink, for me a real challenge, but they suffer hugely, have a massive impact on their quality of life, mainly driven by this vicious itch scratch cycle that drives the eczematous skin inflammation. And very often it's not just the skin itself, but there are loads of different factors feeding into the skin inflammation and the disease of the patient. So, for instance, food or respiratory allergies. There is the sleep disruption that is very often profound. And there is this link with anxiety and depression that we see in a lot of our patients. And of course, skin infections, a major issue, again, driven by the repeated itching and scratching. I'm very lucky that I can work with a multidisciplinary team. We've got not only pediatric dermatologists in our severe pediatric eczema clinic, but also clinical nurse specialists. Pediatric allergist works with us, a clinical psychologist who only deals with pediatric dermatology. We work very closely with our sleep medicine department as well. And of course, our research efforts, especially our clinical trials, both on established conventional treatments as well as novel systemics, are very much integrated into this clinical setting. Let me just give you an example of a typical case from our clinic. So this boy was 12 years old when we saw him the first time. He was, like most of our patients, referred by another dermatologist to us. He had severe atopic eczema since early life and dependent on potent topical steroids. In fact, our colleagues had also experimented with ultra-potent anti-inflammatory treatment previously. But despite all of this, he had recurrent infective exacerbations that led him several times into hospital. He had a high level of anxiety and depression score on the questionnaires that we routinely use in our clinic. He had severe hay fever and asthma, and that was feeding into flares during the hay fever season. And he got worse with phototherapy. And he developed high blood pressure and renal impairment on cyclosporin. So he really needed something else to treat his eczema. All our patients attend structured nurse-led education. That's both in the clinic, but we also have a program for teenagers and parents that talks about eczema treatments, how to spot complications in eczema. And it's also an opportunity for patients and parents to share their experiences. So he went to that. There's the story around the recurrent skin infections, of course, very typical when someone with the eczema is severe and not very well controlled. It is, in those settings, often useful to take a skin swab and see what you're dealing with in terms of sensitivities. Could this potentially be an unusual organism, methicillin-resistant Staphylococcus aureus, or maybe even a PVL staph? Always something to think about in those with recurrent deeper skin infections. We take nasal swabs, not just from the patient, but also from the whole family, and then use nasal antibiotics to eradicate the staph carriage that sometimes can be an issue there. We recommend diluted bleach baths, usually on a twice-weekly basis, to help at least the prevention of future skin infections. And very rarely, I would even resort to using oral antibiotics, usually at half the therapeutic dose, as a prevention measure, but that would be extremely rare. Our patient also saw our clinical psychologist and had habit reversal training with her. That's very important when it comes to making that itch-strat cycle more conscious, giving patients methods to distract themselves. She usually brings them some meditation techniques as well. And importantly, because of her training, she was able to address his anxiety and tendencies to have depression. And in those where that's not enough, we would get our liaison pediatric and adolescent psychiatrist involved as well. Food allergies at this age, at 12 years, usually not so much of an issue, certainly not new ones, but it's worth thinking about. So we already knew from his past history and assessments and pediatric allergy that he was strongly peanut and egg allergic and was clearly avoiding these foods. And there was no history to suggest that there were any new food allergens that might be involved in driving his eczema. But there was this story around his significant hay fever and asthma. So we arranged lung function testing through our pediatric allergy team, optimized his inhaler technique, also prescribed some additional nasal corticosteroid spray and oral non-sedating antihistamines to help that situation further. Just have a look at this video of this patient of mine here, scratching in his sleep, and the parents very kindly gave me permission to share this video. 90% of our patients have disrupted sleep. That leads to tiredness during the day. It may be a potential link even to attention deficit hyperactivity disorder that we see very commonly in our patients, and certainly will feed into disruption of the circadian rhythm. And there is increasing evidence that that may be fueling the skin inflammation and indeed potentially systemic inflammation. And I'm currently leading a research project called Mind and Skin. We're investigating this link between the itch-stretch cycle, sleep disturbance, and systemic inflammation potentially coming from the cutaneous inflammation, potentially leading to brain inflammation as well. Hay fever and asthma will be feeding into the sleep disturbance, certainly if your airways are blocked up, so the hay fever, for instance, isn't well controlled during the hay fever season. I rarely use sedating antihistamines because they can lead to drowsiness the next day, and there's evidence that they impair REM sleep. Working with our children's sleep medicine department has been really helpful here because they can help with sleep hygiene. They very often use melatonin as a more natural way of telling the body when it's time to sleep, and that can be very helpful in our eczema patients too. And then it comes to me as a clinician to select a potential alternative treatment for this patient who had already been on cyclosporin, as you know, but had an impaired renal function. So how do you choose the right drug in this scenario? We've been very fortunate that the National Eczema Society in the UK and Eczema Outreach Support, our two main patient representative bodies, have worked very closely with us to develop patient information leaflets that also speak the language of teenagers. This is something that we're doing in collaboration with the British Society of Paediatric Dermatology as well. So, you know, we've got quite a range of medications we can choose from. There is methotrexate, for instance. There's mycophenolate mofetil. There could be, in this case, azathioprine, just to name the conventional immunosuppressive drugs. Cyclosporin, in this case, obviously was out. And then there is dupilumab as well. Rather frustratingly, the current body of evidence is very small. We only have a limited number of randomized controlled trials that recruited children. The rest of the evidence comes from case series and case control studies. 156 patients, pediatric patients, were included in 6 trials of treatments that are not commonly used. So that's, again, very frustrating for me as a clinician wanting to use an evidence base to inform my clinical decision-making together with the parents. And where pediatric patients were included in adult studies, very often that data is not separately reported for the children. Partly to inform a future intervention study, we went on to conduct an international survey called TREAT amongst 8 European countries to understand how pediatric dermatologists and allergists across Europe prescribe conventional immunosuppressive medication. This was in the pre-dupilumab era, published in the British Journal of Dermatology in 2013. Here we used a standardized scenario of a teenager who had failed topical treatments, antihistamines, and phototherapy, and asked our colleagues what they would use as first, second, and third line treatment. We also asked about the length of treatment they would usually go for, the minimum and maximum doses, and so on. And what we found was not surprising. There was huge variation in the way these systemic drugs were used across European, and we also did a separate North American survey along the same lines. So this is not an easy clinical decision-making process, and it's really a journey between the parent, in this case of pediatric patients, and the doctor, weighing up the pros and cons of conventional and systemic therapies. And for the doctors, it may well be about the short-term efficacy of a medication, whereas the patient may be more interested in the long-term effectiveness. Other factors are adverse events, both short-term and long-term. There may be rare but potential serious adverse events years down the line may be important for physician and patient choice. Quality of life, another very important factor. So how much does a medication improve quality of life, specifically around itch and sleep? Route of administration is important for children. Very often they hate needles, so a drug like dupilumab may be less appealing than a medication that's given either as a tablet or solution. And then monitoring tests. Some medications are considered very safe and don't need much monitoring, but others, certainly the immunosuppressive drugs, would need regular drug monitoring as well, which is an additional burden on the patients, the parents, but also the clinical team looking after the patients. And then certainly in my context in the UK, cost plays an important role. And eventually I have to follow the guidance that comes from our National Institute for Clinical and Care Excellence, NICE. And they very carefully look at how much improvement there is in quality of life for a given cost. So weighing of these factors up, the pros and cons, is very much a mutual decision between patients, parents, and the doctor. So coming back to this patient, he had failed cyclosporin, and in fact, at the time I saw him, I didn't have the benefit of having access to dupilumab, as it was only available in adults at the time. So I went for methotrexate as my second-line systemic medication. Just to flag up that we're currently running a national multi-center trial called TREAT, where we're comparing cyclosporin with methotrexate in pediatric patients aged 2 to 16. They're treated for 9 months, and then they're followed up for 6 months, because we want to know whether, this is the hypothesis, methotrexate is better at switching off this cutaneous inflammation even after medication is stopped compared to cyclosporin. We're not only looking at drug effectiveness and safety, but we're doing a quality of life assessments, a careful cost effectiveness analysis, and this study has got a very detailed mechanistic component where we want to understand how the two drugs switch off the cutaneous inflammation. The study finished just before the COVID lockdown. We're now in the process of analyzing the samples. Hopefully the study will be published next year, so watch this space. And then there is now dupilumab, which is a great addition to our armamentarium. As per NICE regulations in the UK, I'm only able to prescribe dupilumab if a patient has failed conventional immunosuppressive medication. You'd be familiar with this medication. It's given under the skin. It targets interleukin-4 and interleukin-13 signaling, and it does that because it fortuitously binds to the interleukin-4 receptor subunit, which is part of the IL-4 and IL-13 signaling pathway. It's been shown to be very effective both in adult settings, but also increasingly in pediatric studies. The loading dose depends on the patient weight with a 60-kilogram cutoff. It's given every 2 weeks, and surprisingly, maybe there are no safety requirements. This is a very unusual scenario. EMA stipulated that Sanofi, the company producing dupilumab, didn't have to run a post-marketing authorization safety study for dupilumab because the study is the drug is considered to be so safe. Very few adverse events that are of note here. Yes, people can get localized injection site reactions, and there is conjunctivitis as a potential side effect. The studies report quite a wide range, between 10% from clinical trials to observational studies reporting up to 30% patients developing conjunctivitis, but this is adult data. And from my experience in our pediatric patients on dupilumab, it seems to be quite a rare event. So coming back to our case, we addressed his skin infections, his allergies, his sleep disturbance, and psychological comorbidities. He went to see our clinical psychologist to do some habit reversal with him, and she also addressed his anxiety and depression. He had failed cyclosporin via another dermatologist, but then received methotrexate through us for 1 year with a very good response. So we actually didn't have to use dupilumab in him, even if it wasn't available at that stage. And he's now off treatment with no signs of a significant flare. Just to show you some pictures of his skin now. So he's done really well. Thank you very much, and I'm very happy to take any questions.
Thank you very much. And again, very detailed, very useful input there from Professor Floor. And we've had a question from one of the audience that says, will the slides be available? Yes, they will be. And you'll be able to see, indeed, watch the whole session again on the EFA website and probably also through the EADV platform. We're now going to invite a couple of members of the panel to join us, and if they can put their videos on, we can see them. So the two people who you've just seen share their stories, Magali Redding and Professor Carsten Floor, are here with us, and we have two other members of the panel. So we have Gitte Suzanne Rasmussen, who is a specialist nurse working in this area, and we also have Professor Erka Valovirta, who is a pediatrician and allergy specialist. So we have 4 members of the panel, and you, the audience, are welcome to ask questions at this point and share your ideas and your thoughts. So let me start while we're waiting for some input, specific input from the audience. Let me start by asking the panel, We just heard there, both from Magali and Professor Floor, just how challenging it can be living with atopic eczema and how getting a good relationship between the healthcare professionals and the patients and their caregivers is critical for quality of life. So panel members, how can we enhance that relationship with healthcare practitioners who are busy, have got lots of paperwork to do, and in these times of COVID, probably got under tremendous stress. So how do we build and enhance on that? Gita, would you like to start us off?
Yes, thank you. As we already have heard from Ms. Magali, it is very important to bear in mind that the patient's outcome should be measured based on the assumption that patients need to gain confidence, knowledge, and skills, and to learn to live with the disease. And we have to invite them into collaborative processes and activities, I think. And I think we can support these collaborative processes in several ways. And in our clinic and in our research, we use patient panels, maybe one answer to build collaboration. And we recently invited adult patients to the panel discussion with nurses and doctors at the Aarhus University Hospital. And the meeting was facilitated from staff from our Knowledge Center of Patient Involvement. And I must say the patients were very clear in their key points. And we learned that a mutual positive relationship with the healthcare professionals was crucial to them. And it was described as a foundation on which they developed their skills of self-management. And their opportunity to be involved in the co-production and the collaboration with us as healthcare professionals. And I think we learned that they needed our acceptance of their personal knowledge of life, and that their experience should be taken into consideration in the treatment and self-management decision making. And we found in this panel it was a very fruitful method to improve the collaboration in daily care. And the members of the panel also suggested that panel discussion should be a part of the introduction to students and new doctors and nurses. And I think it is a very method to build a collaborative relationship and invite patients into collaboration and co-production of managing the things they have to do in daily life.
Okay, thank you.
Yes.
Let me turn to Erika. We've just heard a little bit about how you can rechange the training for healthcare professionals so they understand the importance of developing that relationship. How do you see building their relationship with the patients? And obviously you work in the pediatric area, so it's not just the patient, it's their family and caregivers. What do you do in your everyday practice to enhance that relationship?
Yeah, first of all, thank you for all the speakers. Just wonderful presentations. I'm a pediatric allergist, and the challenge is that parents do not necessarily understand what is atopic eczema as a disease. We have to start explaining the inflammation and what that means, how it is treated, how we manage the patients, and we have to guarantee the continuity of the care, because there is much, at least in Finland, there is a lot of doctor shopping, because parents, they consider atopic eczema many times to be only a symptom of food allergy, and they are demanding allergy testing. So I think the continuity of the care is very important, and it's not only the doctor we need, as we heard from Mrs. Redding. We need skin nurses, we need psychologists, we need also dietitians. So, and we have to, as was told, inform the patients in a right way. what is it all about? We understand the burden of the disease, and we can discuss about that, and we have to discuss about that with the parents, because in the case of child, as we heard, it is, and also the previous podcasts, it is the problem of the whole family. In Finland, we have a great system. There is the so-called healthy baby clinic. 98% of children under the age of 6 visit on regular basis these healthy baby clinics. So the information should start already there, and the information and even some training. And in addition to that, we have developed so-called evidence-based current guidelines. They are mainly meant for primary care physicians and nurses to harmonize and unify the diagnostic procedures and treatment and management of atopic dermatitis. But we also have developed from these evidence-based current guidelines a patient guideline, patient information sheet, what is really known about the disease, what are the treatment options, how to use the treatments. We have many videos how to use corticosteroid creams or basic ointments. So there is really a need for continuity of the care in the whole healthcare system. Healthcare systems in Europe, they differ, of course, and there are different possibilities, but the collaboration between primary care and specialized care should be very, very easy. And when patients know this, they are more confident with the situation. They give same message from everywhere, and then they start to understand what is this disease.
Yes, thank you. And in fact, I think the point you made about the importance of there being a general understanding in the public as well as in the family about what eczema is, and more importantly, what it isn't, is critical, because Magali's video explained that the reality and the difficulty for a child going to school and experiencing, stigma and negative messaging. If everyone understood it more, it would be helpful. Professor Carsten Floor, your presentation was so good that we have lots of questions from the audience from it. So perhaps I'd like to take a couple of them before we get into the technical ones, which ask about how you did your treatment. Somebody's asked an interesting question, which I think might be worth exploring, which is, what's the role of vitamin D? Now, I know that in the current COVID crisis, there's been a lot of interest in the role of vitamin D, and that large parts of our population don't have enough of it. Is there anyone from the panel who's able to give us a short answer? Is there a role for vitamin D?
So vitamin D is measured in all of our patients routinely. The reason being is that a lot of my patients, practicing in central London, we have a multi-ethnic community of patients. A lot of them have got racially pigmented skin, so at least their parents, even if they're second generation and born in the UK, came from Pakistan, Bangladesh, India, or have very dark skin types. So, for instance, people of Caribbean descent. And it's very well documented that children with these skin types, in the bad weather that we have in London and the UK as a whole, as you know, will have low vitamin D levels. And a lot of them end up being supplemented because they are deficient, partly also because children increasingly spend time indoors rather than outdoors. You're aware that UV light is important in the conversion of vitamin D into the active form. However, thinking about the research side of this and atopic eczema treatment, there is, as far as I'm aware, no real convincing evidence that supplementing someone who's vitamin D deficient with vitamin D will significantly impact on the atopic eczema in a positive way.
Okay, thank you. And I think you were very careful in your wording there to say, what we're looking for is better outcomes for patients. And there's no evidence of significant impact. Magali, I'd like to maybe bring you in at this point, and you can share, if we ask the question, what else is needed before patients are getting the kind of care and support that they would need in a timely way, appropriate care. Professor Floor showed, how you might have to change different treatments to see if something that works, and you describe that in your own video. What else do you think is needed from a patient and their family's perspective?
I think the support network is absolutely essential. Yeah. It's something that whilst healthcare professionals can be very nice and understanding during clinic appointments, they're very short and they are not able to provide emotional support or practical help on a daily basis, of course. So surrounding yourself with people who understand what you're going through and don't think it's just a small patch of itchy skin, as you hear quite often, and also educating others, really important. You mentioned schools, going into schools, but it really does take quite a lot of confidence to do that, actually, to go in and speak to the management of your child's school and say, this is actually something you need to take seriously. So I would say definitely finding this support network around you through a patient group or within your community, and building that confidence to speak to others and explain what eczema is and especially the impact it has on your child and therefore how to meet their needs.
Excellent, and thank you for because we're out of time. It's been a fantastic session this morning. To the audience members who have submitted questions specifically to Professor Floor about his presentation, questions about how he's, on what basis you would change or adjust the treatments. We don't have time to answer now, but we will gather those questions, and if Professor Floor is okay to answer them, we will make sure they're answered by email, so you will get a chance to do that. But thank you very much to all the members of our panel for sharing their inputs. Thank you for you. Well, I can see that we have 180 viewers, so joining us early in the day of what's going to be a packed agenda at the EADV conference. Thank you very much. If you have more questions or you want to find out more about it, please visit the EFA website where we have a lot of information. And thank you for your support in trying to make quality of life better for people with atopic eczema, their families and caregivers. What we've shown here today is partnership and slowly working together in a careful, long-term relationship is the way forward. We know that we need to work beyond the health sector with carers, social sector, education, because this is an issue that particularly affects children. But there's light at the end of the tunnel. To all of you, I say, stay safe, have a good day, and thank you very much. Goodbye.
Bye-bye. Thank you.
Bye. Thank you.